and welcome to the presentation on consent and release in primary care behavioral health settings.
Okay, well, hello. Thank you so much for attending our webinar today. This is Kathy Hudgens. Before we begin, I have a couple of disclaimers, and not just the ones that they ask us to do for CFHA, but I'll go through those as well. But I wanted to recognize Dr. Sandy Rose, who has been a very critical member of our research team. She is the Director of Behavioral Health at the Godwin Community Health Center. She is the brains behind all of us. We always laugh about that, but she is unable to be with us today, but we did want to recognize Sandy and her contribution to our work. We have not had any relevant financial relationships during the past 12 months, even though it would have been nice. Learning objectives, I won't read those to you so we don't lose time, but we hope that we will meet these learning objectives, and we hope to get your feedback in that way. There will be a learning assessment at the end for CE credits, and there will also be a question and answer period conducted at the end of the presentation. And if your questions, we don't have time to answer them, or we don't get to those, we will answer those if you will make sure that we know how to contact you to answer your questions at the end and afterwards. Before I get to my first slide, I have another disclaimer. First of all, I want to say that none of the information or the advice that we're giving or recommendations that we're giving today should be in place of legal advice, and so just wanted to cover ourselves in that way, because you should always get legal advice. But the information that you'll be hearing about today is the results of the recommendations that we gleaned from a research project, an ongoing research project, because we continually update it, which includes content analysis of what is coming out in terms of policy on the web and through communications, and also from a survey of legal and professional experts that we continue to stay in contact with. We also want to say that we recognize that policy is struggling to catch up with practice of integrated care in general, but especially with the PCBH model. However, with the burst of energy around the standard of care, many states and federal governments are making tentative steps toward revising policy and laws. So be aware, and that also includes your own professional guild. So with all that being said, I'm going to start. And one of the reasons why we start with the commonalities in behavioral health ethical codes when we talk about consent and release is that when you're placing behavioral health providers in a primary care setting, there's a cultural change that we need to be aware of. And we're also working from multidisciplinary behavioral health teams. So we know that behavioral health providers in primary care can come from a variety of licensor types. So understanding what is common and what we bring to primary care that might change some of the policies or might complicate things is very important. And then, looking at this, we also want to make sure that we're aware that we are practicing in primary care and not in a traditional specialty mental health setting. However, we bring our own ethics with us. So there are things that we found common when we started looking at all the types of licensure groups, and client welfare was central to a lot of the reasons why we have a lot of patient protection policies. Practicing within our own competency is really important to most, if not all, of the provider types. Prohibiting exploitive and intimate dual relationships, and attaining informed consent for treatment was probably one of the most important and central to what we are looking at. The other things that we found were there's a focus on protecting client confidentiality, and then helping clients reach self-determined goals and autonomy, which is really central to that self-management piece of the PCBH model. maintaining awareness of our own values and biases and helping others do that in our setting as well, which sometimes is a challenge when that's not part of the value system of the focus of that particular setting. Pursuing ongoing professional development. We I think all professions have that in the PCBH model. And then confronting colleagues demonstrating unethical, illegal, and incompetent practice, which is not necessarily executed in the same way for all licensure types. So Pete Fifield stuck this one in because this slide, because one of the things we find is that, and I want to say, if it says if the law says, well, even if it's not the law, if it's a policy or our ethical guidelines say X, and we are doing Y, there is bound to be a problem at some point, and this is where the contention happens. We may have conflicting values or ethics, or we're going, medical providers are going from HIPAA as their baseline, and we have another level of guidelines that we're working under. There's always that contention. So the first thing I want to talk about is informed consent. So one of the recommendations that we found when we polled experts and we started looking at best practices was to put the informed consent in the patient handbook, which some states don't, or sites don't have a patient handbook per se, or the initial paperwork. This seems to really help set the stage for the integrated care, professional relationships, and the types of services that are provided that would be atypical of just a primary care practice that does not provide behavioral health. And so you might want to put in there the exceptions to confidentiality, that your notes will be integrated, so you'll be sharing information. So if you're allowing this patient to understand the process and they sign it, then they are aware. HIPAA and the 42 CFR Part 2 notice, if that is also applicable if you are a program, which we're going to talk about in a moment. Something else that we find really important is the BHC or BHP's role in the treatment team. So if a lot of our sites where we work will put something in there about how we are a team-based organization, that you will be provided services that would include and list those services. We have some sites that also include oral health. And so understanding that we are working toward your health as a team, and you are part of the team, and that's always something I think that helps them with this informed consent. The other thing is the patient bill of rights, if it's state mandated, and I know from my colleagues, Pete and Steve, in New Hampshire, it is state mandated that there is a patient bill of rights. So some of the other issues that we want to talk about briefly or be informed about is that informed consent varies by state and discipline. We found this out when we tried to operationalize what informed consent might look like. And so my recommendation to you would be to understand what your discipline requires and also what your state has, if it has any regulations or guidelines for informed consent for behavioral health. And then when you're putting all that information into that front matter or that initial paperwork, make sure that it's understandable, and if your patient requires additional help understanding it, make sure that that is taken care of in the beginning. You're going to revisit it, but make sure that it's in language and it's understandable, and if they have questions, they have the opportunity to ask those questions before they sign it. And the other thing would be to introduce the providers in a way that reflects the role. We want to make sure that our patients understand that we are a team, and whole health care includes a lot of aspects, including your behavioral health as well as your medical care, but making sure that when you are introduced into their particular case, that they understand what your role is. And some professions require that that you announce that you are a licensed whatever, And some sites will allow you, because you're on the team and it's a team-based approach, just to introduce what you are actually doing with that patient, but just make sure that they understand it, because there's nothing worse than a patient who realizes all of a sudden that you are a behavioral health provider and not a medical provider, and some folks just don't feel very informed, and it feels kind of bad for them. And then the patient should be given that consent. We talked about that in the initial paperwork, but also during the warm handoff, you should revisit that consent and just mention briefly, and this could be from the physician and also for you, to say, I just want to remind you, in your initial paperwork, we talked about our team-based approach and how you might be offered services that would also include some behavioral health. And so when I'm working with you today on your, say, sleep, hygiene, we're talking about your health behaviors that may or may not be affecting your wellness. So that's kind of the script you might want to use. So we are going to try something different with this webinar. We are going to have a poll for you all, so we can sort of see what our audience has to say about some of the topics that we're talking about. So Polly, you want to set up that poll, and here's the question. Okay. How long are we going to, I guess we'll take another minute for the poll.
So it looks like, Kathy, almost everyone has responded. About 81% of our audience. Oh, we have a few more votes coming in.
Okay.
Just a moment more. And it looks like 55% say yes and 45% say no. So right down the middle.
Huh. Wow. How exciting. Well, maybe that'll be something that we can talk about later as we provide more recommendations. Wonderful. Thank you for participating in the poll. Okay. So what are some of the main factors in determining your patient care policy? What we know is that the most rigorous patient care policy trumps all others. So sometimes it's the federal law, especially if it's 42 CFR Part 2. State laws also can be placed into that factoring. So we have found that some states have even more restrictive consent and release laws, and that will trump HIPAA. And then we also find that some states interpret 42 CFR Part 2 more rigorously than others, and so that's the one that you have to go with. We also have ethical guidelines, and we try to blend those as we go into multidisciplinary groups. But we have to really have those conversations when you're putting those patient care policies into place. And then agencies and organizations also have their own level of policies, and that also may trump even the most rigorous state and federal law. So another recommendation we have when we're talking about informed consent, and I mentioned this a minute ago, is that the warm handoff. Assure that informed consent that you have informed consent before intervening. So before you enter into the case and start working with the patient, you need to have some things in your mind. Now this is typically more so for sites that have maybe a hybrid version who might do more traditional care instead of the brief model, but it's very important. But to think about this in a way that if you're doing, the closer you do psychotherapy, the more informed consent that you really need to have, because you're going to be getting in greater depth. And that also changes the sensitivity of the information. So the deeper you go and the more psychotherapy you're doing, the more that informed consent is important. And we found this when we did our research, that for those sites that were doing some type of hybrid version where they have traditional as well as a brief model, they really had to have different types and levels of informed consent. But the warm handoff is the beginning of it all. So, thinking about this as well, as you're trying to blend the different types of providers in a primary care setting, we found that there were shifts that needed to happen, and this is the classic paradigm shift. But these are also cultural shifts. So for us as behavioral health providers, we consider the consent as an ongoing process, as opposed to for medical providers, there may be several things that patients do that are just assumed that go on in primary care, and they're used to having that done. So, they don't say, do you mind if I take you down here to get your lab work done? I mean, you might have a provider who does that, but you typically don't continually get informed consent. The other thing that we found that was interesting is that there's a lesser restriction on exchange of information in a typical primary care clinic, because the assumption is we're exchanging information to be able to treat our patients, and we bring in another level of restriction for that exchange. And having to understand each other's culture and the addition of the complexity and sensitivity of the behavioral health issue. But that does not assume that those behavioral health issues were not being addressed before the behavioral health provider came on site. It's just that understanding what those restrictions might be. And this might mean that the behavioral health provider, come closer to the middle and let go of some of those traditional, especially mental health restrictions that we have been trained to do. And that doesn't mean that you're not providing ethical care. The other thing is identifying our roles when we gain consent. Typically the provider doesn't come in and say, hi, I'm a board certified blah, 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 blah. He just comes in and say, hi, I'm Dr. So-and-so, and how can I help you today? So those are things that are a little bit different. So another recommendation we have is how the primary care provider introduces you to the patient. So ask yourself, what does the patient think I do? Do they think so does the behavioral health provider come in after the primary care provider says, oh, well, so you're having difficulty with your sleep. We're going to bring in a team member who is a specialist in that. Do they know that you are a behavioral health provider before they start sharing the things that are keeping them from sleeping? The other thing is to make sure that your notations, your documentation in your EHR is reflecting what you're doing. So especially in the PCBH model, we had a lot of questions about the difference between a progress note and a process note. So the process note is your traditional psychotherapy note. I can tell you now that our medical providers that we work with would not sort through a psychotherapy note anyway. That's too much information, too much process. So it is appropriate to have an integrated EHR if you use a progress note. And there are certain things that you can use in that progress note just, that are excluded from a psychotherapy note. And Pete is going to talk about that in a moment. So our next question for the poll is the role of the, so Polly, we're going to start the poll. Is the role of the BHC explained to the patient at the worm handoff in your setting? Yes or no?
So Kathy, it looks like most have voted, and it's 95% yes.
Yay! Okay, awesome. Love it. All right, I'm going to hand it over to Pete now, and thank you so much. Pete, do I have to, Polly, do I have to, oh, okay, I figured this out. Okay. I'm handing it over.
This is Steve's section.
Oh, I'm sorry. Steve. Well, I just handed over the wrong person. So sorry.
That's okay. Can you get the slides back?
Okay. All right.
Okay. Well, hi, everybody. HIPAA was actually designed in 1996 to make life easier, believe it or not. It's a relatively liberal statute, liberal law that really defines the base of what we do around informed consent and confidentiality. It dictates the use of disclosure of all exchange of information, both internally and externally. But you may find that a lot of states and agencies, such as mine here, have much more stricter rules around informed consent and confidentiality, which is one of the issues that Kathy talked about earlier, where medical stance, both licensure and regulatory, may be different than BHCs. Next slide.
Oh, I'm having trouble here. Oh.
So, Polly, here's our next question. This question is important because knowing your role within your practice really sets the tone for where informed consent goes, how deep you need to go into informed consent, and also limits of confidentiality.
Okay, Steve, it looks like 35% report that they provide consultation on health and wellness only. No one indicated that they provide and bill for psychotherapy only, and then 68%, just changed, 68 and 32% said that they both provide consultation on health and wellness and provide and bill for psychotherapy. So it looks like 68% do both.
Okay. And that's important because if you are providing and billing for psychotherapy, informed consent really has to allow the patient to know who you are in terms of your credentials and your licensure, what your role is in their health care, what you intend to do, and how you're going to do it. Pete, actually, I'm going to hand this to you.
Pete?
Yeah, I'm here. Yep. So this gets into the communications piece, and what we did here with these slides is we divided them up into internal and external communications. So internal communications we have identified as entities within your integrated team, within your organization. For instance, the organization that I work at, we have oral health, we have medical health, we have behavioral health, we have family groups, we have parenting groups and prenatal. So we consider all of those entities within our organization internal communications. An external communication in this case we'll discuss in a second. So one of the really important things here, and I know we're talking about the patient-centered behavioral health model, what's becoming more and more prevalent these days is this expert concept and a lot more prevention work. So if you're not a substance use disorder specialist, then you don't have to worry about all these other restrictions. So you can document internally as needed, and this internal communication can be, in many ways, communicated equally and evenly throughout all of the providers in the team, keeping in mind, once again, that we're utilizing the progress note format, not the process note format. And if you're a clinician in a program, which we're going to talk about much later, you must have what we call either a release or a QSOA, which is a Qualified Service Organizational Agreement, similar to a business associate agreement, but slightly different. But we suggest having one of those signed with every major entity within your group and any external entity that you're sort of communicating with regularly, such as billing services or labs, etc. Could you advance the slide? So recommendation number 6, for internal communications, always document the minimal necessary information. So this is the need to know information, the progress note. And this is sort of really important because there is a lot of scuttle, I think, about not what makes a progress note a progress note and a process note, but what information can actually be shared. So if you go on to the next slide, I want to talk a little bit about what a progress note can include. So a progress note, it actually can include quite a bit of information. It can include any sort of information about medication, so titration up or down or discontinuation of the medication, etc. It can include the diagnosis, and in this case that states, in our situation that might state quite a bit. The person's functional status, and that might be a GAF assessment or any sort of functional status you utilize in your individual facility. The treatment plan, so what we're going to do next. Any symptoms the person is displaying, which obviously is quite a bit of information that the medical providers and you and other members of the team can utilize. The prognosis, so where are they headed? Where are we going to go from here? Not only in our treatment plan, obviously, but what we believe their situation is and the strengths, weaknesses to help this person autonomously move forward. And the progress to date. So if you take all of this into consideration, there's quite a bit of information here that the provider can use, and it's not necessarily considered process. So all that process stuff Kathy alluded towards this earlier, they're not going to read through that, but this very needful information that we just mentioned in that progress note can not only help the other medical providers, but I found in my situation and people that I've consulted with, it's enough information for you to move on from session 1 to session 2 to session 3. So you don't necessarily need all of that other very sensitive information. External communication, I'm going to pass this back to Steve because this is actually your part, bud, and you can take that.
Okay. Yeah, HIPAA defines what are elements of a proper release of information in order to share notes or sensitive information, which is separate from 42 CFR Part 2, which has a more stricter set of rules around how to share substance use information. It's important that releases of information for external communication indicate whether or not the person separately allows for the release of substance use information. HIPAA also really defines releases of information as another element of informed consent, so that the patient really needs to know what information is being shared, why it's being shared, what the duration of that sharing is, and they need to understand all that intimately before they sign. The signature actually indicates informed consent. And then the second bullet here is really important, that the higher the sensitivity of the information, the higher the need for a release of information to share, and the more informed the patient needs to be in order to consent. Next slide, please, Kath. So actually, this is back to you, Pete. We're playing ping pong. Pete? Well, I'll pick it up, Pete, and you can jump in. Our fourth recommendation is if you're a substance use disorder program, and the statute defines program as an entity that...
No, I got it.
Okay, go ahead.
Oh, yeah, right. So if you're a substance abuse disorder program, and we will talk a little bit more about this in a second because these are sort of what actually makes up the program. If you are considered a program, you need to lock your notes under special security, such as substance use disorder or SUBAB. But it really is, that's a level of confidentiality that needs to be taken to the next level. And there really is, this isn't necessarily about progress process note. If you are a program and you are diagnosing or discussing a substance use disorder, it's its own beast. It sort of has to be treated in its own special way. Now, keep in mind, though, the ISPRT protocols, screening, brief intervention, and referral for treatment, I alluded towards this a little bit earlier. This has been going on in Colorado for years. I mean, 7, 8 years ago, we started an ISPRT program in Colorado. In New Hampshire, we're starting up one. It's been going on in New Hampshire for about a year or two now, maybe even more, and other states are utilizing this protocol too. It sort of has its own requirements as well, and I'm going to talk about that. Next slide. So are you a program? And a program, this really means, this is really important because the way 42 CFR Part 2 identifies information needing to be sequestered in its own little private spot is determined by two things. One is, are you an individual entity, so you as an individual or a facility who holds itself out as providing and provides alcohol and drug treatment. So if you're saying, we here at facility X treat drug and alcohol treatment, and then you are considered a program under one aspect. Number two, or B here, an identified unit within a general medical facility which holds itself out as providing special drug and alcohol treatment. Or if you're a medical person or staff of a general medical facility that holds themselves out and their primary function is something like providing alcohol and drug abuse diagnosis, treatment, or referral for treatment. Now, this last piece here is really important because there's a huge movement towards primary cares providing Suboxone treatment for individuals. So in that case, an entity, sort of a medical provider, a physician that has an endorsement and specialized training to provide Suboxone, they are, by definition of 42 CFR, considered a program. Same with if you are a licensed alcohol and drug counselor or, in Colorado they have a certified addictions counselor. Whatever those special credentials are, if you hold those, then you meet one of the criteria of being a program. The other criteria of being a program is if you receive any funding from the government. So if you have a tax exempt status, or if your organization receives any IRS assistance by grants or tax reductions, or if you receive any federal funding whatsoever, even if it's not for that drug and alcohol program, you are considered a program. So if you fall into any of those, if you fall under both of those things, you need to follow the 42 CFR Part 2. And if that's not clear, it's not clear to anyone, so don't feel bad. But it really is a sort of a simple thing. You have to meet two parts. If you are doing the job and holding yourself out as doing a specialized substance use disorder job and your facility receives funds from the government in any way, you are a program. Next slide, please. So a qualified service organization agreement, and it's very similar to a business associate agreement as we talked about before. A lot of times a QSOA helps individuals that are considered a program coordinate care and communicate with other medical entities or other entities within that same organization. We've even some states translate this very literally, and some translate a little bit loosely. So it really does behoove you to check with your your state translation on this. I think we're utilizing QSOA as a standard that will allow myself, who's a licensed alcohol and drug counselor, to communicate with the medical providers if there's any sort of thing that we call cross-contamination. So if and this is going to get a little bit squirrely, but if the individual talks to the doctor and there's no mention of drug and alcohol use, and then I'm introduced and I go in there and I say, I'm a licensed alcohol and drug counselor and a licensed clinical mental health counselor. The doc wanted me to talk to you about smoking, and that patient's like, what my real problem is I drink every day. I have to really think about how I'm going to relay that information back to the provider. Obviously, it's really important information, but this is where we're talking about informed consent. And it's really, really, really important that the the patient has, you know, the information, the knowledge to make that decision about what they share with who. Could you slide, next slide, please? So, question number 4. I myself and or others of my profession within my organization are considered a substance disorder program. Under what I just explained would be considered a program, those 2 parts. You receive federal funds and you hold yourself out as providing specialty care. And as noted earlier, this is why this is important is it comes back down to the informed consent for the patient. Do they have enough information to make a decision that's appropriate and safe and best for them?
Okay, Pete, it looks like about 80% of the audience has voted and 70% indicate no.
Okay.
And 20 yes and 10% are unsure.
No, that's good, because that 10% that's unsure, believe it or not, Sandy Rose, a colleague of ours that Kathy spoke of earlier, she did this, a survey like this a few years back, and it was probably about 40 to 50% were unsure. So it's good that at least we're you know, people are more informed. Okay, so the next thing we're going to talk about is the electronic health record or medical record, however you decide to term it. Our recommendation here is to, if have different sensitivities within your electronic medical record, that you can sequester or isolate or set aside any important documents that you deem sensitive enough to be sequestered. So what we do here, we use GE centricity, and we have 3 designations. Behavioral health, which is sort of what we use for a true progress note. Like, this information can be shared, it can be released to the receiving office with no special permissions. Then we have mental health, the MH, and then that one possibly can include some very sensitive information, not necessarily process information, but information about their history, such as, you know, sexual abuse or violent abuse or some sort of very sensitive history that they're not just willing to have you know, sort of released to another entity. And of course SUD, and you could use that, that's just substance use disorder information, and that falls under that 42 CFR that we were talking about. So what we do is we identify these 3 documents that we can open up, and they're automatically set to a certain sensitivity, and then we give providers the privilege to see certain documents, and all of our medical providers have the privilege to see all of these documents as it is now. So, but they're not allowed. The important thing here is then when we talk about the difference between consent and release, this here helps us release only information that's appropriate and not release inappropriate information. And then the last thing here is obviously create specific office policies for releasing sensitive information, and also consider chart audits. So if we're operating under the assumption that people should only be viewing records on a need-to-know basis, really only a chart audit is going to tell you that. So a lot of this stuff is an administrative piece or an IT piece, but we're informing you all here today whether you have that, play that role or not, just so you're aware of that. Next slide, please. Kath, next slide.
Sorry, I don't know why it's not going.
Okay.
Again. Holly's thoughts on why it's not? Oh, there we go.
There we go. Okay, so the next thing we're going to talk about is health information exchanges, or they call them regional health information exchange, health information exchange organizations, etc. These are becoming more and more prevalent throughout the nation, and what a health information exchange is a secondary or affiliated entity that organizes massive amounts of regional information, both medical information, substance use information, etc. And it stores that information and sort of allows other entities to access that information. So What's really important to know here, there are two sort of terms, three terms that are really important. One is the originating center. So the originating center is the center or the organization that creates the information. The affiliate member could be a billing entity or a lab entity and or the health information exchange themselves. They're an affiliate entity. The third sort of word that we really need to think about, or the term, is third-party entity. So what we're going to talk about right now is just between the originator and the affiliate member. And if this QSOA that we talked about earlier, if you have one of those in place between your organization and the health information exchange, it's a bidirectional QSOA, you can exchange sensitive information between your organization and this health information exchange. That does not mean, however, that health information exchange can then release that information to a third party without another QSOA with that third party. So we just, pretty much the QSOA, if you think about it, it's a way of assuring everyone's accountability to the safety of that information and securing that information. If those QSOAs aren't in existence, then you have to have a patient consent to authorize every release to that health information exchange. And we're not going to get a lot into this today because health information exchange and confidentiality and privacy and all that, it's a whole session on itself. But once again, I just wanted to sort of bring this to the light because this is something within your state that most likely is already happening. In New Hampshire, we don't have one in place yet that's like working seamlessly, but in Vermont, in Maine, they have one in Vermont, and in Massachusetts. So all of our surrounding states are utilizing this technology. So this is just sort of an awareness sort of slide for you all. Next slide.
I don't know why I keep having trouble with it. Maybe I just, okay. So I think this goes to me now. Is that right, Pete?
Yes, it is. It's all you.
All right. So confidentiality, we talked about this just a little bit earlier, but so the licensing laws really dictate confidentiality to some degree, and they vary by discipline and state. We did not find too many states that trumped the federal, but 13 states we did find are compared to the same type of level of confidentiality that is between a lawyer and their client, which I think is very interesting. We also found that the greater the sensitivity of the information, the more the protection. So again, if you're doing traditional psychotherapy, then you probably want to make sure that you are putting those the right things into place. So communication between providers, we talked about this earlier. So be aware of those 42 CFR and HIPAA laws that are in place for confidentiality. And again, the QSOA. The funny thing about this in my state that I'm in right now working, we have the attorneys, the state attorneys, are interpreting 42 CFR quite stringently, and they do not allow for a QSOA. So be very conscious of what your own state laws dictate. In terms of protecting patient privacy, again, the most restrictive law or policy trumps all others. And then you have to make sure that you're working with your practice manager or your risk manager in your site to make sure that you have the things in place that also cover your own licensure laws. And then cross-training is really important. We have been trying to get our sites that we work with to identify one person who would be abreast of those types of changes, who would be monitoring any type of communication that's coming out from either the state or the federal government, and then also working with policy folks on the state level to make some changes or to educate those policymakers so they can make some changes that will bring the policy up to the practice. So here is our next question. Does your state require specific conversation around informed consent during the initial patient visit?
And Kathy, this is Polly. I actually missed doing a poll for this one, so I apologize.
I'm sorry? I didn't hear Polly.
Kathy, I missed doing a poll for this one, so I apologize.
Can you hear me, Polly?
Yeah, I'm sorry.
You're kind of breaking up.
Can you hear me?
No.
Sorry, Kathy. We don't have.
We'll just move on. We'll move on.
All right, it seems to have some different poll. Let's move forward.
Okay. So I'm going to speed up a little bit because we're running out of time, and I want to make sure we have room for some questions. So just a few additional ongoing recommendations that we're seeing emerge in the literature and the guidance. Our first recommendation always is to access legal counsel. That's never changed. No one's ever said just don't talk to a lawyer, just make up your own stuff. So everyone still agrees on that. We do know that states are beginning to change the laws to meet the challenges to the new standards of care that are coming out in integrated care. So keep up with those. Always defer to the most stringent patient protection standard, always. Cross-train, communicate your roles of the staff, and communication is key because miscommunication and misunderstanding of each other's roles and our own guidelines that we come to our teams with can really cause a problem. And so in order to understand also the need for flow and ethics to balance, because sometimes they intersect, those communications are very important. And that can happen in your implementation team if you have an implementation team, or if you have opportunity to help write the policies. It's a really good idea. And then just make sure that you are continuing to revise your policies and procedures, because you don't want to get stuck in an outdated, restrictive policy that could actually grease the wheel if you could increase it to meet the new standards. So here are our post-assessment questions. I guess we've been questioning you all along, and I would say that these questions are things for you to ask yourself. Polly, do we need to ask these out loud?
Kathy, can you hear me?
Somewhat, yes.
Yes, we do need to.
Oh, no, you're still breaking up.
Kathy, can you hear me now?
No.
Hey, Kathy, why don't we, can we switch over and just start taking questions, possibly?
Yeah, let's do that.
Yeah.
So we have a couple questions that Polly has typed to us. Let's see. All right. If primary care physicians at an FQHC prescribe Suboxone off-label for the chronic pain patient and not an SUD, are they still automatically considered a program due to the other prescribing of Suboxone and or receiving federal funds as an FQHC? Pete?
I would say no. The criteria outlined by 42 CFR specifically states that you're holding yourself out as a substance use disorder specialist. So if you're providing Suboxone off-label for pain, that's not an issue. Another example of this would be naltrexone. It is considered a substance, to remove cravings for alcohol, but it has other uses. Same with benzodiazepines. You can use Librium to help titrate or to help aid the detoxification process for a patient coming off alcohol. But if the provider is not holding themselves out as a substance use disorder specialist, Librium, for instance, without falling under 42 CFR. So it's not as much the medication that you're prescribing, it's the profession you're you're presenting that you do. I hope that clarified.
Okay. So we had another question about the difference between a process note and a progress note and billing. This one came in separate from the webinar, but wanting to know whether or not if you're billing for psychotherapy codes for brief because there are no codes in their state for integrated care, do they have to use the psychotherapy note?
Steve, I think this is you. It's got you written all over.
Yeah, I'll take that. So if you're billing for psychotherapy under a specific CPT code, you need to use a progress note. A lot of payers actually dictate what is in a progress note or the elements of a progress note. You do not want to use a psychotherapy note or a process-oriented note for that. It won't hit those elements that Pete outlined earlier. It won't be compliant to the payer for billing.
Okay, wonderful. Okay, we have one other question. It was about the identifying yourself as your license as opposed to your role. So I think as we talked about, it would depend on your licensure type. There are some behavioral health providers who are not required by their license, either their state or by their guild, to identify their license, but to identify what they are doing to get informed consent. Pete and Steve, do you have any other thoughts about that one?
And sure, yeah. Just in the special interest group conversation that was going on in the email, there was a lot of conversation about this, and I think this is a gray area. And I hate to say that. There's a lot of folks out there that say, I'm a psychologist, and I want that person to know that they're getting the skill of psychologist, whether we're working on sleep or weight loss. It doesn't matter. So I really think it does necessitate you looking at what your informed consent in your guild states. In the state of New Hampshire, my licensed clinical mental health counselor requirements state that I need to inform that patient of what I'm doing and my clinical status, my licensure. So in the state of New Hampshire, I'm supposed to do that. All states are not the same, so you're going to have to actually look at not only your state requirements, but your actual guild licensure requirements to answer that question.
So we have about a minute left. I'm just going to say one last thing, and then we're going to have to log off and say goodbye and say thank you. But one last thing about that, I just want to piggyback with what Pete said. Please start working with your state licensure boards or your guilds to try to get the policies to step up. I know that APA is really working on that. I know that a lot of the different ones are working on it, but continue to be an advocate to promote the behavioral health provider's role in primary care. Well, Polly was unable to get her microphone to work again, so I am going to say thank you to all of our participants, and we really appreciate you being with us today. And please let us know. You'll have our contact information if you have questions. Not to say that we will answer them in a way that will be as most helpful as opposed to your legal counsel, which you should be looking at as well, but we'd be happy to help. And thank you so much.